And joining us today, Dr. Lee Tessler, neurosurgeon and partner in Neurological Surgery PC and assistant clinical professor of neurosurgery at NYU Langone Medical Center, specializing in brain tumors. Dr. Tessler, welcome to the Daily Dose.
Thank you for having me.
Why don't we start with some definition of terms and talk about tumors, primary versus metastatic?
So, tumors of the brain essentially come in two varieties. Those that arise from the brain itself, in other words, primary tumors, and those that arise from somewhere else in the body and spread to the brain, metastatic tumors.
And talking about primary tumors, I find it very interesting that you don't define tumors in terms of benign versus malignant. What do you define them as?
So that's true. Patients often will come in and when they get a diagnosis ask, is this malignant? And the truth is that tumors that arise from the brain itself are defined on a scale from 1 to 4. And they generally do not spread anywhere else in the brain. They grow locally where they are. The terms 1 to 4 define how aggressive they may grow back. And so really they're not benign or malignant. They're just defined in terms of how aggressive they may come back, and therefore what do we need to do to keep them from coming back.
So meningiomas are generally the lower grade tumors?
So meningiomas come in a few different varieties as well. Typical meningiomas are defined as grade 1 meningiomas. Those tend to be the least aggressive. Meningiomas also have the unique property of growing from the covering of the brain, so not from the brain itself. They grow very slowly, at a rate of about 1 millimeter or 2 a year. By growing that slowly, they push the brain out of the way at a very slow rate. Symptoms that patients often get will result from very large tumors. Because the tumors grow so slowly and push the brain out of the way at such a slow rate, the brain has a chance to adjust to it. And so oftentimes, once a patient has symptoms, the tumors can get very large.
So the diagnosis of those lower grade meningiomas can be a challenge then?
It can be. Recently, with the advent of more MRIs available, we are finding these at a much more frequent rate because people are getting scans for other reasons, and we're finding these meningiomas before they cause symptoms. Depending on how large they are and where they are, that might be a reason to treat or just to watch and wait with the hopes that maybe the patient will not have symptoms from it.
And we talk about the fascinating part of all this, the treatment. It is fair to say, and pun intended, you're on the cutting edge here of an extraordinary new range of alternative treatments.
Absolutely. So when we talk about treatments, we're generally talking about either slowing down or stopping the growth if it hasn't produced symptoms yet, or reversing symptoms, eliminating the development of further symptoms. In general, that's divided into two categories. One being surgical resection, so actually going in and taking them out. The second being what's called radiosurgery, a form of radiation, very high doses delivered right to the tumor itself in the form of gamma knife or cyber knife. In terms of actual surgical resection, these tumors can be challenging. Although they are benign and grow from the covering of the brain, they can sometimes be very near important structures, such as the parts of the brain that control movement, control speech, or vital nerves that control vision or hearing. And so the newer techniques that have been developed in such a way that we can remove these tumors from those areas with very little morbidity or damage to the surrounding brain. Some of the newer techniques that we have are in the form of stereotaxis, and what that refers to is obtaining preoperative MRI images, then creating a three-dimensional computer brain of the patient, a computer model of the patient's brain, and using that model to navigate during surgery to go after just the tumor and stay away from some of these vital structures. Once we're near the vital structures and have to be very careful about taking it away from some of these nerves, parts of the brain, or blood vessels, one of the newer techniques that we're using is something called the carbon dioxide laser. What that does is it allows us to very precisely remove these tumors from those areas without damaging the underlying structures.
Boy, that's all absolutely fascinating. As we said, it was once thought that surgery was the last resort, the last option. Is that still true with all of these new types of treatments?
For the most part, we do reserve surgery as sort of a last resort, with the exception being that in very young patients, if we find these very early on, and we know they're going to grow at a rate of 1 millimeter or 2 a year, and that patient may be 30 or 40 years old and has a large life ahead of them, we may decide to do surgery up front to prevent that growth later on. For some older patients that may have other medical comorbidities, may have other reasons not to have a surgical procedure, we may then resort to either conservative management, just watching these, or CyberKnife, Gamma Knife, one of these forms of radiosurgery to help control it. One of the main reasons that a lot of these tumors weren't operated on in the past is because the complication and morbidity associated with just removing the tumors was worse than if we let them progress. Now with some of these newer techniques, we're getting much better at removing these tumors and getting people back to their normal lives within just a few days.
Incredible new technology and so much at your disposal now in the 21st century and looking forward. Once upon a time, when you heard brain tumor, the patient's next question was, how much time do I have left? That is no longer true.
That's true. We're now at the point where we can really treat a lot of these diseases as chronic diseases and not terminal diseases. Now, not only with surgical technique, but also the advent of some of these new treatment options in terms of clinical trials, tumor vaccines, and different types of chemotherapy, we're really not only extending patients' lives, but extending their quality of life so they can actually get back to their normal life, get back to their families, and treat this as just another chronic disease.
With so much research ongoing, who knows what's on the horizon, but it's an exciting time for your field and a great time for all of us to explore all these options should a diagnosis like this come before us or a member of our family. Dr. Lee Tessler, neurosurgeon specializing in brain tumors, we want to thank you very much for joining us on the Daily Dose.
Thank you.